Hello, everyone. Thank you for joining us today. On this webinar, we'll be talking about connecting HIV/AIDS, gay and trans rights, harm reduction, and drug policy. My name is Naja Kassir. I work at the Canadian Drug Policy Coalition as the Community Engagement and Education Coordinator. Um, so I am joining you today from Jojage, Munyang, colonially known as Montreal, which are unceded Kanien'kehá:ka territories. Um, so I will invite everyone if you want. You can introduce yourselves in the chat. Say who you are, where you're coming from. Completely optional, obviously. We will have a panelist speaking French today. So if you could turn on your interpretation, we'll post the instruction in the chat. But you'll see a little globe at the bottom of your screen, and you just have to select the language that you want to listen to this webinar, and it will automatically interpret. I'm getting a message that the chat is disabled. That is not supposed to be happening, but I'm not surprised because we are unfortunately not running from our Zoom license, and so I don't have access to the back end. But this would be the last time that this is happening, fortunately. So if we run into any type of technical difficulties like that, I apologize. And we should be fine for our upcoming webinars. Speaking of upcoming webinars, you can mark your calendars. We have one coming up on Bill C2, Borders and Drug Policy on November 26th at 9:30 Pacific time, 12:30 Eastern time. And yeah, we'll have a Q&A at the end of the webinar. So if you have any question, you can type them in the Q&A box. And also, you can upvote questions. So if you, through the webinar, look at any of the questions that you would like to see answered, just click the little thumbs up button next to it. This way, when it's time for the Q&A, I'll know which one people want answered the most. And without further ado, I will pass the mic to DJ Larkin and Janet Butler McPhee to let you all know a bit why we're doing this webinar today.
So DJ, I think we agreed that I would kick off. Hi everyone. I'm Janet Butler McPhee. My pronouns are she, her, and I'm one of the co-executive directors at the HIV Legal Network. I'm speaking to you today from Treaty 13 territory, which is also known as Toronto. At the HIV Legal Network, we promote the human rights of people living with HIV or AIDS and other populations who are disproportionately affected by HIV, punitive laws and policies, and criminalization. We do this in Canada and around the world. So you can see that our work certainly connects HIV, harm reduction, and 2SLGBTQ plus rights. People living with HIV, people who use drugs, and members of the 2SLGBTQ plus community are three resilient groups of people who've been marginalized, criminalized, and subjected to laws and policies that affect their daily lives. And that happens all too often without any consideration for their lived experience and expertise. I wish I could say that this was historical, but as we all know, the persecution continues today. And while we don't criminalize 2SLGBTQ plus people in Canada, we are seeing a scary pushback on trans rights. And in Canada, we still do criminalize people living with HIV who could be prosecuted with non-disclosure, and also people who use drugs, many of whom exist in public spaces as the housing crisis rages on. The HIV Legal Network is now more than 33 years old, actually, and we've seen a lot. First and foremost, the HIV pandemic is at the origin of many harm reduction programs. The HIV and AIDS pandemic also made it urgent for advocates and activists to adapt practices, interventions, and policies to reduce new HIV infections among people who use drugs. Around the world, HIV prevention often remains an entry point for the establishment of harm reduction programs at local and national levels. HIV prevention, by design, is often twinned with drug policy reform. We also know that the HIV movement, which focuses on people's lived experience and centering human rights for all, rejecting criminalization, it's been a source of inspiration for the harm reduction movement and the broader drug policy movement. HIV, harm reduction, and queer rights movements share so many similarities on how change has come about and continues to come about. All three rely on civil disobedience, activism, and community solidarity and love. And all three movements are grounded in the need to center the autonomy of people with lived and living experience. Today in Canada and internationally, we're seeing multiple intersecting crises that are driving these movements. Human rights for many groups are being trampled, including members of the LGBTQ plus community worldwide. Advocacy efforts for drug policy reforms and access to harm reduction are now mainly driven by the relentless drug poisoning crisis that's killed more than 53,000 people since 2016 in Canada, and many more deaths from stimulants that are untracked. People who use drugs are disproportionately without housing, and so their lives are on full display in public spaces. And worldwide, the relative risk of acquiring HIV was 14 times higher for people who inject drugs than for people in the overall adult population. Here in Canada in 2023, the proportion of HIV diagnoses attributed to injecting drug use was 18.2% and accounted for 28.4% of new cases among women. So those numbers are staggering. And at the same time, Canada is the only G7 country with rising rates of HIV, which is shameful. So this feels like an important time to have a conversation about HIV, harm reduction, and queer rights. We're so pleased to be here co-hosting with our colleagues at the Canadian Drug Policy Coalition, and I'll pass it over to you, DJ.
And I will admit with some shame that my buzzer is going, so hopefully you don't hear it. Uh, Hi, folks. I'm DJ. I'm with the Canadian Drug Policy Coalition. You're not going to hear a lot from me. Thank you, Janet, for doing the heavy lifting. I'm just excited to get to the panel, but I wanted to take a moment to say that we're thrilled to be co-hosting this webinar, thrilled to have the panelists that we do. Over the last few years, we've seen an extraordinary rise in rhetoric that is pulling communities apart, that is asking us to blame each other, to give up on the solidarity that we know saves lives, to give up on the solidarity that is grounded in love and evidence and practice that is born out of community and that we know works. Whether it was those initial needle programs or supervised consumption before it was authorized by government or compassion clubs, solutions come from community. They're born out of that loving relationship, and we can really only do that if we stick together. Right now, we are seeing a great deal of moral panic and blame and misinformation targeted towards trans people and drug users and all sorts of communities. And the goal there really is to pull us apart, to make people feel fear so that we won't stand together. And so we wanted to come together to host this webinar to hear from these amazing panelists about the experiences within communities, those loving practices that work, the evidence and the practice that we need to move forward, and to just remind ourselves that we are stronger together. And so when we hear that politicized rhetoric, let's not be fooled, and let's hold the line together. So I don't really have anything else to say. I'd actually really rather hear from these panelists. Thank you so much.
Thank you so much, Janet and DJ. While I was busy trying to figure out all the logistics, I forgot to say we're sending all our love. 21 right now, who's experiencing issues just accessing HIV treatment, whether it's because of their legal status, because of them living in rural or isolated areas, for economic reason, and for people internationally who are also struggling to access their medication because of the dismantling of USAID and the impact that that has had. So I wanted to start with that. I'm going to invite one of my favorite person to open this panel. Her name is Anais Montenegro, and she's basically going to be telling us about some of her experiences immigrating to Canada in the late 80s and 90s and navigating just navigating the circumstances at the time. So Anais,
hello, I'm here. Hi, everyone. Thank you for having me, Naja, and to invite me to share my testimonial. as a person from the community who's been here and since the beginning of the pandemic, I'm Anaïs Zeledon Montenegro. I'm based in Montreal since 1985. When the pandemic started to really be amplified within the population, at that time I was within the gay community, so I was starting to really hang out with different places and had friends in different places in Montreal. And I started to notice that this illness started to ravage our community. It was starting to really break us, and the society, it was starting to really alienate us. And of course, there was all this stigmatization that was getting quite intense. And there was the fear of this lethal illness, and we were starting to see the losses of our friends around us. So we started to mobilize ourselves. And in 1989, all these organizations that I've worked for, whether it was in public health or, for sure, this is why I'm sharing my testimonial today. It's because I want to also make connections to what's happening today. So there was Cactus, who had just opened its doors in 1989. And namely, that was the year that in December of that year, we had the AIDS conference in Montreal. And we participated in the huge demonstration so that we could let our voices be heard, because at that time, there weren't adequate medications to prevent HIV. So we had a lot of people that were feeling this distance that this illness was creating. So when Cactus opened its doors at that time, to encourage harm reduction for people who are drug users, it really, allowed to put into place some material supports and also supports for sex workers. So for people doing that work in 89, I wasn't in that environment at that time, and within the trans community at that time, but following this, in 1995, 1996, despite the more available medication, the trans population and the HIV positive population was further stigmatized, since most of these people from the trans population had become sick, and it was often those who were also intersecting with sex work that were most affected. And as I was called in by another trans person, and I then was able to make my coming out. And then when Aztec, the organization for whom I work today, then began, I became a member of its organization, and they opened their doors to then allow for trans people in the community who were affected by the illness. So they had created this project within Cactus that was already underway, but there's only the founder who was there at the time who was active. And so, we were having conferences and meetings, and to be able to say, how can we fight against stigmatism or stigma? So I started sex work at that time. And at that time, even my generation, since the 60s, 70s, we couldn't find other work. So, if we couldn't access surgeries and things, then, so despite all this discrimination against the trans population, it was, it was quite strong, this discrimination. So we really had to unite ourselves so that then Aztec could take more space. So earlier, we were having some issues with webinar transmission, so I'm going to try to slow down and calm down a bit. Technology is not my strong suit, but so we knew that the population in 1997, there were new movements starting, and me as a sex worker, I was hearing that there were people who were scared to be revealed as being HIV positive, to being outed. So we were trying to protect ourselves in our own little world. So often, in the community, if we run into people in the streets or in the bars, like, we were afraid. So I started getting involved in community work until the point, up to the point where I started working for Aztec as a social worker in the community. And that way I would be able to really take on the migrant population support role. So in 2015, we started seeing a lot of trans migrants. There was a lot of discrimination against HIV positive people who couldn't ask for, they couldn't make asylum requests. So they couldn't access vaginoplasties because of their HIV positivity. So that was then absolutely prohibited. So it's only when the government changed this law, and then at that time, our doors opened for the broader migrant population, and we had a huge number of people who were coming to us. And often they would come to us and we wouldn't necessarily know they were HIV positive, but also trans HIV positive populations were migrating towards us. And we had doctors then who wanted to work with us, but only if people had their federal status documents, because in Quebec, it's often asylum seekers are often among, they were having the most issues. And in the federal government, they had what they called the medical protection policy. And that's how the clinic Agora, with whom I've been working with for over 20 years, very closely, they were there to help not only the migrant population, but also the broader trans population. And so we're always developing more connections and networking, but it's not easy, especially in Quebec. When we look at the last reports from the ministry, we're starting to feel even more discrimination from them since the pandemic. But thanks to you all and the, and all the allies, we're still protected by our friends and the people who are helping us a lot, but who are encouraging us and are opening doors for us and assisting us with webinars such as this to be able to say, hey, the trans population is still being targeted by all this stigmatization. And so since the beginning of the pandemic, so I've gone through all of that period of 40 years in Quebec. And I've been a member of the community and working and having a lot of accompaniment with from people who are also seeking a better life here in Quebec. I encourage everyone to share our fears, to share, because we're trying to work with other communities. And that's, if ever you have questions, I'm a little bit nervous sharing, but I've done a lot of webinars, but today with everything, I'm feeling a little bit stressed out, but here we are. So, but I'm a living proof that, I have that this illness is here since the beginning, and we're still fighting for our rights that we've had since the beginning of this big ravaging that it's until today.
So thank you to all the changes, the different how drug systems, the different medical systems have changed, and I am still happy to be here and to be able to continue with the struggle and to work with you all. There's so, you know, being in my 60s, I've gone through a lot, and I'm here to keep on working through the struggle with you, a fight this against stigmatization that continues to happen. Thank you so much for having me. Thank you, Anais. We still have some time. And we're gonna let people add their questions in the Q&A. So we don't want to, we'd like to have you around and answer some questions for us. So I just wanted to ask you, what's changed a lot for you since the 90s, and what stayed the same in terms when we're talking about access to services, especially for HIV services for the LGBTQ community? What's changed, and then what stayed the same? I maybe can't go into details on the clinical or medical side. I more have heard my friends' testimonials in the 80s, in the 90s, if you were HIV positive, and we'd watch about like how things started to evolve, and then there was the different, like the antiretroviral drugs coming out in the 90s. And obviously, we were taking all these drugs, like all these pills back in the day. Just there's this whole array of different drugs that people were having to take. Now, obviously, the medical difference, one pill that we take in with a new, and then there's a PrEP, right? And you can get injections. So that's changed so much. And like, there's doctors who actually accompany individuals who might not even be HIV positive, and they can have access to PrEP, and trying to make pill form of PrEP and an injection form. And that's all like new things that have come out in 2025. And that's huge changes when we talk in terms of treatment and medical situations from my time. One pill instead of 10 pills that we were taking back in the day. And then obviously the others access are very different. Like sex work is not like it was before. we used to have more direct contact with our colleagues who were working in sex works, like at the bars. We had places where we could all be together, and that's not the same now. People reach out to us at Aztec, obviously, because now my relationship is changed at a professional level. I'm at Aztec. And then, so I'm thinking about the approach when you talk about mental health, psychological approaches. Yeah, before we were really meeting in the street, in the bars. However, the way that we're stigmatized is still the same. You know, that we're still taking, even if the pill is easier than getting injected for especially sex workers, because there's so much discrimination and prejudices, especially if you're trans, if you're in a situation of homelessness. This idea, if you're maybe using drugs, the stigmatization is still so heavy. And at least we have spaces like Aztec where everyone is welcome to come. So if you're trans, if you're experiencing homelessness, if you're whatever marginal situation you find yourselves in, we have those spaces and there's this support. We've seen some of our support changes. We see that we do have more allies. It's, not just a little sector of the population that only is experiencing the disease, right? The HIV, we see it, people have a broader understanding. We see it represented on TV and stuff, but it could be more up in clear and in people's faces. And how I see my activism today, I want to really still keep on fighting for sex work. That sex work should be decriminalized. It should be seen as any other kind of work because it continues to discriminate sex workers. Sex workers don't feel comfortable to speak up, to make sure their rights are respective, to be able to get support. And so at least we're still fighting that they feel comfortable to come to us. And how do we, confidentiality issues are so important because people are scared. And people continue to be stigmatized. They can't share their name. They're all, even within the community, sex workers are still stigmatized. And obviously our work is very affected by this. We're not always people that you'll see in the street. So we're less visible. The bars aren't there for us to meet. The girls couldn't come, and then clients could come and meet us at the bars. That's not a thing anymore. So it's harder for us to meet up to support each other. And girls will be reaching out for needing different materials, and they might have to come and get it at Aztec. But before we could just like meet up with them in the bar and give them all the safer supplies materials. And you could have more personalized interactions rather than on a phone and the internet. And then if not, now the only in-person meeting situations we have is in Aztec. So then we just wind up talking on the phone and email. And I think it's way better to like meet in physical. I don't know if that I answered your question about what it was like back in the 80s and 90s compared to now. And so in terms of drugs, medically, socially speaking, and just the fact that we meet up in different networks, that changes so much. Thank you so much. That really answers the question. Thank you, Anais. It's so interesting to hear you speak about the evolution of all of this and how there's this kind of type of isolation that maybe has been created because the community isn't able to meet up in public areas or these personal areas because sex work has changed. So that's really interesting to hear how that works. So thank you, Anna. And I just want to give you a small anecdote. And just listening to you speak, I was reminded that I don't suffer. You know, maybe I wasn't. I used to be really hurt. Um, and now I have more hope. There's this hope for our community, the LGBTQ folks' life that we can continue. So, and the accompaniment, and so there's a little bit more hopefulness. I think I see that as change, and to talk to you about seeing the sufferance of our friends that happened in the 80s and 90s, and people were just dropping like flies, and the amount of people that we lost, a very like from so many generations, and it's changed it's affected our community of the generational representation, and who, when I was transitioning, I was losing people, and there's maybe was less representation of the trans community, but we were also losing friends, and the pain is still there. And I think it's important to make links with how the virus in the 80s and the 90s. We lost more people then, but we're still losing people now, and we can't forget that. Despite all the medical advances, we can't forget that we're still losing people. Thank you so much for reminding us that, and like highlighting that, and remembering the human aspect, that suffering continues, and it's not just by accident. It's because our government is not acting. They have made clear political decisions and policy decisions to make, we're talking about drugs. We're talking about people who are close to us, people who work with us. And this is not an accident. It's clear the decisions of the government and their inaction. So thank you so much, Anais, for speaking with us.
I'm gonna switch to English now. For our next panelist, Richard Elliott. Thank you for coming today. So if you could just introduce yourself, how you got into this work, and kind of continue onto this thread of talking about these connections between harm reduction and queer and trans rights, and how things change, evolve, what didn't change, what didn't evolve. Yeah.
Happy to do that, and thanks for the invitation to be here. Welcome, everyone. I'm coming to you from Chipuktuk in Mi'kma'ki, also known as Halifax, Nova Scotia. I'm a lawyer and a human rights advocate working on HIV-related human rights issues for a few decades now. The past executive director of the HIV Legal Network, and currently vice chair of the CDPC Board of Directors. And as I've mentioned, I've been working for a few decades on human rights issues related to HIV. And that obviously includes a fair bit of advocacy in relation to harm reduction and drug policy reform. And I was very pleased last year to be the author of a report released by the Legal Network on strengthening harm reduction for queer people who use drugs. So these connections between the different movements, the overlaps, have been very much on my mind. And I want to, I think there are numerous connections between advocacy for LGBTQ plus rights and liberation and advocacy for the rights and liberation of people who use drugs, including through needed harm reduction services and an end to punitive drug laws. But I want to posit just three for purposes of discussion today and in the interest of time. The first is shared history. The second is practical reality. And the third is at the level of fundamental principle. So let me just say a couple of things about each of those. First, with respect to shared history, and this picks up on some points that Janet and DJ made in their opening remarks. Obviously, the shared history of the public health crisis that is the HIV pandemic and the human rights crisis that the HIV pandemic has intensified for both gay communities and people who use drugs is central to this discussion. And it's not just the shared, in some ways, experience of living under the shadow of death and disease for so long, but also living under the shadow of the responses, or in some case, lack of response, to the needs of both communities that were rooted in similar stigma and prejudice regarding deviant sexual conduct and the deliberate scapegoating for political power and political purposes of those communities, amongst others, at the expense of policies and programs that were rooted in evidence and human rights. Now, on the flip side, in some cases, well, in many cases, it was communities that played a major role in actually creating the services and the responses that were needed by those communities, precisely because they and we were being ignored and scapegoated. And in some settings where LGBTQ rights plus organizing was less advanced, it was under the rubric of responding to the HIV crisis that a lot of LGBTQ community organizing and advocacy took a major step forward. That was much more often the case for the development of drug user movements, but it was not necessarily always the case for queer rights movements. But in some cases, it very much was that public health rubric of responding to a public health crisis that created that opening for the development of community and funding, very importantly, for community organizations that provide key infrastructure for mobilization of communities. But it's not just the shared history of being stigmatized, marginalized, disregarded, scapegoated in the context of a public health crisis. There's also, and this is my second point, the practical reality that harm reduction and drug policy are queer rights issues, and therefore these movements are linked. And I say that because, of course, queer people use drugs. In fact, we have ample evidence establishing that queer people have higher prevalence of substance use, have higher prevalence of substance use that I'm going to call problematic for purposes of this discussion. There are also differences, of course, in patterns of substance use, in some of the factors behind substance use, in some of the risks and experiences of harm that queer people who use drug experience that are somewhat different from non-queer people and their drug use. And there's also particular needs of a community of queer people who use drugs that are needed in the response. And there are additional barriers to the services that are needed. So the practical reality is that there's a connection between harm reduction advocacy and drug policy advocacy on the one hand, and queer rights advocacy on the other, in that punitive drug laws and policies and attacks on harm reduction services affect the health of queer people because there are queer people who use drugs. And in fact, those attacks, the rolling back of harm reduction services, disproportionately affects queer people, precisely because we have higher prevalence of substance use, including problematic substance use. And so I think it's fair to say that LGBTQ rights advocates, if they are committed to the health and rights of queer people, that must include queer people who use drugs. And therefore, drug policy and attacks on harm reduction are queer rights issues because they are queer health issues, and health is a human right. So there's that practical reality. Now, whether or not organizations do that, is another question. But it is a reality that should not be ignored. But beyond the fact that there's some shared history between drug user organizing and advocacy for harm reduction on the one hand, and the experience of queer communities under HIV epidemic, beyond the practical reality that queer people use drugs and therefore drug policy and harm reduction are queer issues, there's also, and this is my third point, a fundamental connection between advocacy for queer people's rights and health and advocacy for the health and rights of people who use drugs. And that is at the level of fundamental principle. Principles such as privacy, respect for personal autonomy, including bodily autonomy, and commitment to rejecting moral panics, to challenging the surveillance apparatus of the state and repression by that apparatus are fundamental principles in which both the queer liberation movement and the drug user liberation movement are rooted. And so there is common cause because these are common principles. And this goes back to my first point, which is that this has been illustrated so amply in the case of the HIV pandemic specifically, where we've seen that kind of scapegoating, that moral panic, that denial of privacy, the violation of personal autonomy. If we are committed to those principles within one movement, within one community, then we ought to be committed to those principles in relation to another community, especially one with which we might share a history of experiencing what it means to have those principles disregarded. So I think those are three ways in which these movements and communities are connected. There are many others that we could speak about, and I hope we might at some point. But then to come to the other part of what you posed to me as a question, Naja, about how things have evolved, I just want to make 2 points. And again, many more things could be said, but the first is that I would say the connections of which I've just spoken have been unevenly recognized and embodied in our advocacy, in both movements, and in the implementation of services. So it's not surprising that queer people have been quite prominent in harm reduction advocacy, given the connections that I've mentioned. And yet, the concerns of queer people who use drugs have, I would say, been largely invisible in a lot of drug policy advocacy until fairly recently. And that is starting to change, which is great. Similarly, I would say that despite a body of research that is now a couple of decades old regarding substance use and problematic substance use amongst queer people, there are still relatively few and small-scale services for queer people who use drugs. Similarly, there has not been a lot of attention within queer rights advocacy, with some very important exceptions, to issues of harm reduction and drug policy and the implications of those for queer people. An LGBTQ rights advocacy agenda has not often touched on drug policy issues and incorporated those as issues of concern, as queer rights issues, which, as I've argued, they are. So I think that there has been some invisibility or a lack of acknowledgement of the connections between these two movements, and insufficient connection most of the time in the advocacy by the organizations that make up those movements in most cases. Again, there are important exceptions, and I think we need to build on those. So that's one observation about how things have evolved. And the second thing that I just want to say, and I'll wrap up here, is that we have certainly seen in the Canadian context, but I don't think it's just the Canadian context, in recent years, a tension within organizations between different communities, or what are perceived to be different communities, tension over money, over turf, as organizations have tried to evolve their responses to the HIV pandemic, and which communities are being affected. And I think that it's unfortunate that in some cases we've had a simplistic and somewhat arbitrary pitching of different populations of service users against each other. And it has sometimes been simplified down to it's the gay men versus the drug users. Whose organization is this? Whose space is this? And that has been a tension that within the HIV response, many organizations have had to grapple with. And there's no question that there are different populations with differing service needs. But and it is difficult sometimes to reconcile those needs, especially in the context of limited resources, when you have limited space, limited hours in which certain spaces can be occupied, decisions having to be made within your limited budget about what kinds of services are offered when and to whom. But I think it's unfortunate if those discussions devolve, as they sometimes have, into this simplistic pitching of it's gay men versus drug users. Who owns the HIV response? Who owns this HIV organization, for example? I think that ultimately not only ignores the reality that there are people who belong to both communities, but I think for the reasons that have been mentioned, it also weakens our collective response if we to the abuses that both people who use drugs and queer people experience. And it takes our eye off the ball as to what the larger structural forces are that are having the effect of pitting communities against each other. It's the underfunding of community responses so that people have to fight over limited resources. And to the extent that people are trying to do that, we are not focused on challenging those systems and structures of oppression, those systems and structures of police surveillance, the actors who are fomenting moral panics and scapegoating us yet again, the same communities yet again, for their own political purposes. I think we should not lose sight that that's what's ultimately going on here. So I think that's one thing that we have seen in recent years and that we need to perhaps grapple with better. So let me stop there, and I look forward to hearing what the other panelists have to say. Thanks.
Thanks so much, Richard, for breaking down how those challenges stem from those structural issues, and also just posing those challenges to us here, like attending this this webinar. I think those conversations are very important to have. I think that's why we're trying with this with this webinar series to break down silos and have these conversation and breaking the fourth wall a bit. So I really appreciate. I remind people to please, if you have any question, you can put them in the Q&A box. Our next speaker is Leisha Newman. And Leisha, I would invite you to introduce yourself, tell us how you got into this work and the work that you've been doing around how all these issues have been impacting the Indigenous communities that you work with.
Miigwech. So, ani Alicia Indigenous Makwan Dodam Kichisibi Dojba Naswakwa Da Madawazibi Nishnave Minwa Jaganash Nijnamanadwaganda. So I'm Leisha. I use they them pronouns. I am Bear Clan, mixed Algonquin European ancestry. My Algonquin relations come from the Ottawa River watershed, and my non-Indigenous relations all settled in the Madawaska Valley. And I am coming to you from Sudbury. So as Naja mentioned, I work for, so there's quite a deadly smudge starting up here, for Ontario Aboriginal HIV/AIDS strategy. I kind of got into this work by an accident. I started with OHOS in 2020 as the Two-Spirit outreach worker with the New Horizons for 2SLGBTQ+ older adults program. We're just being in the space, being around community, hearing their stories, seeing their love for one another. It really started to like shift something in me, and I started to really find the value in Indigenous harm reduction and what it can do for community. It's not just about reducing harm from substances, but it's also about restoring connection to self, to culture, to community. And there's just so much power in what can happen when people feel seen and safe and have those cultural connections. So that is what inspired me to get involved with the training and resource development team here at OHAS. I wanted to take that support and the same kind of care and take it onto like a larger scale and make sure that our frontline workers have the tools and resources that they need to continue showing up for community in a good way. And also at the same time, better equip other Indigenous service providers and other healthcare providers in better supporting Indigenous community. For me, this work, it's always been about like connection, compassion, and creating conditions where people can heal on their own terms. So it just, I feel really at home here at OHAS because that's a big part of their messaging. So how do we get here? Like we know that Indigenous communities have been hugely disproportionately impacted by HIV/AIDS. I think it's really important to kind of look at like how we got to this point and like where did it come from? It's not something that just popped up overnight. It's the effects of policies of assimilation and colonial control, right? The same policies that outlawed our ceremonies and connections and implemented the Indian Act, they're all from the same structures that are creating the policies that we're seeing now, like the harmful drug policies and things like that, right? These tools of colonial control, like the Indian Act, residential schools, 60 Scoop, they're all policies that disrupted families, erased languages, and severed people from their connection to land and kinship ties. So uh, generations of this, it has created like a legacy that continues to shape health outcomes today. We really see it in the fact that there are higher rates of HIV and substance use in Indigenous communities. These are symptoms of intergenerational trauma, disconnection from land, and ultimately systemic neglect. On top of that, there's the jurisdictional tug of war between federal and provincial governments of who's going to pay for Indigenous healthcare. Means that Indigenous people are still being denied consistent, equitable healthcare. We saw this directly with Jordan's principle and how our people are falling through the cracks while they're fighting over funding. And so like we are still seeing this happen in harm reduction and HIV care, right? When it came to the safe consumption sites and all of the different red tape that everybody had to go through, or thinking of like the Safer Streets, Stronger Communities Act and how it prohibits municipalities from applying for exemptions from federal law around drug use and things like that in order to start a safe consumption site. You just can't even do it anymore. It yeah, which is like ultimately led us to where we're at now. So we're currently witnessing today's version of the 60s scoop with a unprecedented amount of Indigenous children being in care right now. and continuously being removed from their families at alarming rates. All of this, what it does is it just further perpetuates trauma and instability in Indigenous communities and just creates these cycles of loss and disconnection, which directly influence substance use and HIV risk, particularly within Indigenous women, because they carry the weight of both care and survival in our communities, right? Um, we know that there's a great deal of missing information in test requisitions. All of the data that gets collected is not nearly all of the data that represents us, but we do know that the number one reason people, Indigenous people, are coming for first-time testing is because of heterosexual sex. Often that's through pregnancy screening. But the second is injection drug use. From some 2022 stats from OHISI, we saw that 94% of new HIV diagnoses among Indigenous women were related to injection drug use. And um, for me, that's like a direct reflection of the scarcity of harm reduction infrastructure in Ontario, especially in the north. You basically hit Toronto or Parry Sound, and there's just nothing any further. So there's limited access to needle exchange programs. There are no safe consumption sites. There is no safe supply. We just don't have it. It's not even an option up here. And in the places where harm reduction does exist, where the needle exchange programs do exist, they might not actually even be culturally safe for Indigenous women or Two-Spirit people or anybody Indigenous in that sense, honestly. Um, and then you like add on the additional way of fear of child welfare getting brought in and that sort of thing. And so a lot of Indigenous women are just not accessing the services that they need because all of these structures that have been built over time, they're not for us. They are on us essentially. And it just huge barrier, really, essentially. Um, we also see that like Indigenous women are getting diagnosed later in their infection, so which is a reflection of the mistrust in the regular healthcare system. Um, and then once it comes to treatment adherence, any housing insecurity, transportation barriers, fear of disclosure in small communities, all of those are also barriers that people are running into. If you're in a flying community and the closest place that you can access services is you have to fly out for, that's terrifying. You don't want to have to share that with everybody. And so it's just like, I think that's where like the community aspect comes into play and the advocacy aspect comes into play because we really need to consider the root causes of all of this and not just the outcomes. Like the why, not just the what. Like, yes, we've higher rates of HIV in our communities, but like this isn't about individual risk factors or risky behaviors or things like that. It's about colonial harm and the systemic neglect and social inequities that many Indigenous communities face. Top it off with poverty, lack of safe housing, food insecurity, trauma, all of these racism, and all these things increase vulnerability and make it more difficult to be able to live in that good way, right? It's a larger web of social and structural determinants. It's not just a isolated health issue. Um, then I think I would probably also I think it's also important to kind of look at Indigenous leadership and self-determination. We know what works and what doesn't work. Oftentimes, Indigenous groups are kind of left out of the decision-making and funding processes. Or when we are consulted, it doesn't actually go anywhere, which is the like ongoing colonial paternalism that we've had to face over many, many generations, right? We know that there are multi-pronged approaches that are needed, but are constantly being blocked legislatively by harmful drug policies. And whenever I speak to self-determination, that also means letting communities design their own approaches to HIV prevention and testing and care, things like that, because Indigenous health needs to be in Indigenous hands, which is something that I really value in the work that OHAS is doing, because it's coming from a different approach than necessarily the Western aspect, right? Coming from looking at the whole circle, everything here, we also consider Two-Spirit and gender diverse inclusion as well, because our Two-Spirit people were part of the circle and have been pushed out, right? And we see that data collection methods, they are essentially erasing Two-Spirit people and their experiences, because they're not necessarily getting captured. They get kind of put in with the oh, my dog is having quite a dream. So sorry about that. They get put into like the MSM category, that sort of thing, right? So it's just including the bringing Two-Spirit people into like the decision-making process on all levels, right? And then I think the final piece on that I can speak to on how we can kind of like loop everything back together is I think that to work on like strengthening relationships and not surveillance is a big piece. So like the nature of data collection is that it's often extractive, right? Communities are studied, but then they're not supported. So it's important to include Indigenous people throughout the entire process, from the research all the way through to how they want that research brought back into community. It comes down to Indigenous data sovereignty and how critical it is to ensure research benefits communities and guides real action. Nothing for us without us also applies to HIV surveillance, funding, and evaluation, really. I think that's like I went on a bit of a tangent there. Hopefully I covered everything. Yeah, I guess I'll pass it over to Nadine.
Oh, thank you, Lisha. Yes, Nadine is our last panelist, but I wanted to I just wanted to echo Joseph's comment. Thank you, Lisha, for putting these statistics into perspective. Because when we were starting to work on this webinar, we were noticing at the same time as this data around HIV rates, especially in Saskatchewan, impacting Indigenous women, and these like astronomical rates and disproportionate rates of HIV infections. It was also around the same time that in Ontario, they were announcing the closures of so many safe injection sites. And so for us, this connection was obvious as to why rates of infections would go up when we remove services. And I'm glad that you could share all of this with everyone attending today. So our next panelist is Nadine Sukermani, and leading up to this panel, we talked about, yes, the current trends of the HIV epidemic. We talked about step backs and gains that have been made, but we also talked about community care a lot. And so welcome, Nadine. Thanks for joining us. Really excited to hear your presentation today.
Thank you. Thank you so much, Naha. Good afternoon, folks. I want to start first by showing appreciation and gratitude to the Canadian Drug Policy Coalition and the HIV Legal Network for creating space for this very important conversation. I also look to my panelists, my co-panelists, and want to thank Ane for your connection to the history that we must remember today, where we have come from, as well. Of course, Richard and Leisha, it's hard to follow on all of your on your pathway through this conversation. So I'll do my best. I know we want to leave a bit of time for Q&A, but I'll just start by talking about how I came into this work. So pleased, I've been following the chat to see so many of my Ontario and Manitoba colleagues in this space. I'm joining you from Treaty 13 territory here in Toronto, and this is the traditional territories of the Huron-Wendat, Anishinaabe, Mississaugas of the Credit, and many, many other nations. We also acknowledge at the OHTN the historical context and the global context of not only HIV, but of how we got here and why we do this work. I particularly find it important to ground myself in the beginnings of this work. And the reason I call Manitoba out is not only because of what we're seeing on the ground in the data and in terms of what's happening as far as HIV goes, but because I started this work in the 90s. I was born and raised in Treaty 1 territory, and I started my early career in community health, looking around as a young queer, I call a baby queer, and a racialized cis woman in a very interesting city in the sense of what that looked like growing up in the 80s and the 90s. And what was happening was people were dying. And so I started work in what I call the work harm reduction work before it was called harm reduction. So, you know, being involved in the street outreach and handing out safe supply, handing out needles and supporting sex workers and supporting people in the downtown Winnipeg core. And this was my breeding ground and my learning ground. And it's why I do the work I do today. When Leisha talks about, by us, for us, or not without us, Jipa Mepa, the greater involvement and meaningful engagement of people living with HIV, is at the heart of that. And it's not only, Richard, you talked about the collective response that is needed around communities coming together and working in relationship and in partnership, and that collective response. I think about that Jipa Mepa work and the grounding of our work in that. And this is really about the lived experience, ensuring that people who are living with HIV, drug culture experts, people who use drugs, are centered in this work. So when I fast forward to the question that I was provided was looking at what is the current context, and the OHTN, our mission is to improve the health and lives of people living with HIV and at risk of HIV, using data and evidence to drive change. And for me, that data, that evidence, but change is really where I focus in on from a leadership perspective. In 2025, the epidemic is still here. We've heard this throughout this webinar, and I know all of you who are grounded in this work, this is not a surprise. It's still a thing, despite most recently, for those who are aware, in Toronto, the closing of ACT, which is the AIDS Committee of Toronto, rebranded to ACT Toronto. After 42 years, they're closing their doors. And it really created a space of grief and pause for people in community, and particularly at my organization and those that we work alongside. And we're here to say it's not over. So it's not a victory lap. In fact, HIV is still a thing. And I'll talk about that campaign at the end of my talk when I try to instill or infuse some hope into this conversation. What is actually happening is that the numbers are increasing for GB, MSM, heterosexual women, African, Caribbean, and Black communities, racialized and Indigenous communities, and people who use drugs or identified at risk. And there is always, through this data lens, an understanding of there's a lot of information we don't know. So at a glance, there are over 22,000 people living with HIV in Ontario, over 65,000 in Canada. In Ontario, in 2023, we've noted 723 new diagnoses compared to 589 in 2022. And across Canada, according to the Public Health Agency of Canada, 2,434 new infections compared to in 2022, 1,800. So those numbers don't lie. We know that there's a lot of there's a response that is required in as we think about those numbers, and there's also a lot of missingness in those numbers. So when we think about sex, for example, versus gender, I was in a conversation this morning with our partners who are doing gender-focused work around HIV in the province, and these questions came up. The data only tracks and is limited to, in most parts, sex, male, female, binary. So who's missing? Non-binary people, trans folks, and they may identify and they may show up in one or two of those categories, but they may not. So I always think back to some of my elders in this work who have reminded us, always think about who's not at the table. Always think about who doesn't get through the door. Always think about who isn't getting access to that test. And again, to the cascade, who isn't on treatment, who isn't undetectable, and who isn't connected to care. So when we think about for example, this increase, there's a lot of people who are saying, well, there's been an increase in testing post-COVID. So of course, we're going to see more numbers. So that's a good news story. A lot of people think increasing numbers means, oh no, this is like we're going to get on the, oh, things are really, really bad. What we know is that yes, there has been increased testing. Yes, there's been some increase to linkage to care and treatment. But again, that story isn't an all good news story. What we do know about Ontario, we have across the 95, 95, 95, we've reached 89% who are diagnosed, 85% on treatment, and 95% virally suppressed or undetectable. But one of the reminders that I will make is that that last 5% is the hardest gap to close, because what's worked for many communities is not necessarily going to work for the communities most affected. So when I think of Lisha, what you shared about Indigenous communities, what we're seeing around heterosexual women, for example, the numbers increasing, what we know, and we had a recent conversation about how do we get access to heterosexual men, for example, how do we get them tested, and how do we start to see the fuller picture for them? We absolutely need to think about the intersections between the structural determinants that block access to healthcare, those are still real, and then pay specific care and attention to the communities that I've mentioned. And Saskatchewan and Manitoba, it's an awful thing in terms of thinking about, but there's a term that people talk about, the canary in the coal mine. And if we look at what's going well there is testing, and what's showing up are numbers and an incredible response. And I know people on the ground there are doing incredible things to shift the trajectory. At the same time, we're not always addressing those complex needs. What we don't talk about is the fourth cascade, or I like to call it the first cascade. So we know the three that I just mentioned, but quality of life. If people are not housed, if people are not fed, if the socioeconomic realities outweigh their ability to feel safe and have access to safe spaces and safe consumption, which we've talked about what's happening in Ontario, if they're not thriving and if those basic needs are not met, they're unable to get access to those other three cascade areas. People who are thriving often are white, often are cisgendered men, but they're not all GBMSM populations. They're often people with socioeconomic privilege, living in urban settings with good access to health care. And so when we think about those who are homeless, who are food insecure, experiencing complex mental health and addictions, when we think about those who are using drugs, recently at the OHTN, we did a methamphetamine think tank, and there we heard from GBMSM population specifically talking about how chemsex, party and play, and other addictions challenges are interrupting their ability to gain full quality of life and to maintain treatment and continue to live in the undetectable sphere. People are dying. People are dying from AIDS, along with all of the comorbidities that come along with being on art long term, for years, for decades. We're now reaching the 40th or 40, almost 40th year, where aging is now entering the picture. In fact, when I was the executive director at Fife House prior to coming to the OHTN, Fife House being the largest and only supportive housing provider to people living with HIV in Toronto, we were seeing how incredibly complex the needs of the communities are and continue to be, and as well people dying in our housing, but not always from AIDS, often from other diseases that were coming along as a result of that long-term use. So what we do at the OHTN, because I'm aware that we want to give people a bit of time for questions, is just to talk about what I like to say is HIV in and of itself is not a social determinant of health. However, the social and structural barriers to health equity, and real life are getting in the way of people living with HIV thriving and getting full access to the health care that they need. The story is absolutely repeating itself. The numbers we're seeing are growing, and the realities of a time when my family arrived in Canada 40 years ago are showing its ugly face again. Decades later, we're seeing a growing and a rising anti-immigrant sentiment, increasing levels of racism that, though racism didn't just hit the front page in 2020 when we had colliding pandemics of COVID, George Floyd, and other socioeconomic realities coming to the forefront, but a growing level of violence and gentrification and pushing out of people who are marginalized, pushing out of and closures of safe spaces for people to use, to live, and to thrive. So I'll just want to end with a bit of hope and talk a little bit about what we're doing at the OHTN and here in Ontario. I'll just take a few minutes to talk about tailored approaches, so responsive interventions and a focus on prevention and complex care, building on what we know has worked and then also focusing on what didn't work. For some examples, I had the absolute pleasure to spend some time with Leisha and OHAS at the Indigenous People Living with HIV gathering. It's an annual gathering hosted by OHAS on Rama Nation a couple of weeks ago. At the OHTN, we're meeting regularly with the Black Manifesto group, they've been ringing the alarm about the rates of HIV among ACB communities for a long time. And so we're listening and we're responding and working with them on a plan. At the OHTN, we're investing in clinical interventions for African, Caribbean, and Black communities, not only in Toronto, which is where we are seeing increased rates, but also all over the province. So we're hoping to have at least half a dozen clinical sites specifically focusing on HIV care for ACB communities across Ontario. I mentioned the methamphetamine think tank. And again, I don't like the term think tank, but it's one of the things that that's what they called it. But there we heard and talked about GBMSM communities openly sharing the impacts of PNP and chemsex on their lives. We have also started a program here at the OHTN, and it's a provincial program called VitalLink. And VitalLink is a program that's providing the lab coverage for people who are uninsured as they prepare to get access to PEP and PrEP. And so there's a number of lab costs and lab, clinical things that have to happen. And I'm not a physician or clinician, so I'll call them things. And VitalLink is a way that clinicians can get those covered for their uninsured clients. And then Prep Start, which is a program that's been around for a while, but it's providing free access to PEP and PrEP for people who are unable to access it due to their status or current medical situation. Second thing I'll talk about is better data. So at the OHTN, and Leisha, you mentioned the OHISI data, which is the Ontario HIV Epidemiological and Surveillance Initiative. And I'll just note that word surveillance, we're trying to make a shift to monitoring rather than, but it is a bit of a process to change the names of these things, as well as our OHTN cohort study. And then the development and ongoing work with our Indigenous Data Governance Council, and hopefully soon the development of an ACB Data Governance Council. Focus not only on data governance, but on data sovereignty. Again, back to 4S bias, acknowledging that the data belongs to the individuals who are in community and who are contributing to this, to the data that we share and we present to you. Funding, Leisha, you mentioned this. Funding, we fund research that is responsive on aging with a gender focus, on homelessness and housing. We're looking at non-clinical interventions and approaches to HIV care, and really working again with the communities that I've mentioned to ensure that we're not extractive, but really responsive. And finally, I mentioned that I would talk a little bit about the No HIV campaign. And this is KNOW HIV. So if you visit knowiv.ca, the OHTN is working with community to launch the next iteration of this campaign to really raise the alarm, ring the alarm that HIV is still a thing. And the last final is I want to just ground this talk and thank you again for offering the time to me to speak about this. This work is about relationship, it's about humility, and it's about solidarity, and that we must continue this collective response to ensure that people have access to thrive and to beyond survival, thrive and gain access to the things they need to be a part of our communities. Thank you.
Thank you so much, Nadine, for sharing all of this with us. I would invite all the panelists to turn on their cameras. And thank you again for everything you've all shared. So we got many questions over the course of the webinar, but seeing the time, I think we've answered some of the questions that people asked. But following this note of hope that you shared, Nadine, I'd like to ask the panelists. Someone in the audience asked, Tala asked, I'm curious to know what gives each of you hope for the future of organizing around these issues. And I think just to expand on like what we mean by hope, or like rather than this nebulous concept, I'm curious like what grounds you in this in working together towards actions, principles, and effort in those issues. I'll let you all just feel free to unmute your mic and just share whatever is on your mind.
I'll say something. I'm wondering if the silence in response to the question is perhaps a sign of the times that don't feel so hopeful at the moment. But I don't purport to have enough expertise beyond the context here to say that there's strong grounds for hope in some other places. But with respect to the Canadian context, I will say that two things that give me hope are the progress that has been made with respect to public opinion and law reform when it comes to LGB, and to some lesser extent T rights in Canada. Not that those are secure, for sure, and we should not assume that they are, especially given the ongoing backlash or ramped up backlash against trans people in some parts of Canada right now. But I think it has demonstrated what can be achieved in the course of a few decades of sustained advocacy. And I think that it's not impossible, but it will be difficult to turn back the clock on that. So maybe that's, weak tea. Maybe it's not the strongest grounds for hope, but I do find it somewhat encouraging. Similarly, I would say, although it has not been as much progress, I think there has been a significant shift in public opinion, and there have been some shifts when it comes to policies and programs with respect to harm reduction, much more uneven, much less firmly embedded, I would say, in the sort of polity of Canada than I think an acceptance of gay people and, or at least basic rights for us. But again, there's been a significant shift, and I think there's much more support for harm reduction than there was even 20 years ago. And a recognition that continuing to double down on the war on drugs and punitive responses is stupid and pointless and harmful. It's not a clear majority, but it's definitely a greater number than it was. Yes, and I see your comment, Michaela, and that's precisely why I offered the caveat at the beginning. Yeah.
Yeah, thanks for sharing that, Richard. That's why I thought about, I've been thinking about the word hope a lot this year, and for me it's been more helpful to think about the principle underlying that hope, or like why we are even hoping to talk about these things. For me, for example, like simple things that give me hope is just working in the past and interacting with youth and seeing those reflex around getting drugs tested, around going to get tested, around accessing community resources without feeling ashamed or feeling the stigma around simply just entering a community center. That's very new. I feel something over the past 10 years that I've seen. That makes me feel like, okay, this work on a structural level, who knows what the government is planning, but at least from a grassroots level and just from like a regular like youth just living their life level, to see these reflexes implemented into people's lifestyles, that definitely makes me like take a breather for sure.
Naja, if I can, I just see, hi, Kimberly. I know we crossed paths back when I was at Fife House. There's a question about HIV and aging, and I think I mentioned it in my chat. But yes, this is a particularly important area to consider as we approach the 40 plus year anniversary of the HIV epidemic. And there's good work happening, but I think there needs to absolutely be more. So I mentioned in the research component of work at the OHTN, where we are funding some projects that are looking at aging. We're working fairly closely with a geriatrician who is by accident very involved in aging work in HIV. And the reason I say by accident, Kimberly, it's a bit like yourself. And I know a lot of frontline workers and case managers in housing and homelessness is the disproportionate number of people living precariously who are older. And just the street needs assessment in Toronto showed that we have people, and when you think of HIV, the onset of aging is 55. That's the age we talk about. And then when you see the number of people who are living on the street in Toronto, and I'm sure this is across the country, there's an older population. And then within that, we have a disproportionate number of 2SLGBTQIA folks and then HIV. So Kimberly, to your question, I don't have a perfect answer, but just to say it is absolutely on our radar and it is showing up in emergency departments and it's absolutely showing up in our work. So we'll continue to prioritize. Just Naja, on the heels of youth, I just thought it was important to answer Kim's question and just name that. And I know we're at time, so I'll stop.
Yes, we are. But before we go, I just want to thank all the panelists today for sharing your thoughts, your experiences. Thank you to all the attendees and over 100 people who stuck till the end. We really appreciate everyone's support. We will be sending the recording of the webinar around next week. Everyone who attended or could not make it will have an email, so tell your friends, and we'll share the resources too in that email. Thank you so much to our interpreters also for their hard work of making sure that this webinar was more accessible. So thanks everyone. Have a good one.